Come on. It's right there. Right there. Okie doke. We'll go ahead and get started. We've got a lot of material to get through today. And it's moving forward, so there's going to be a lot of time for questions. And the soft tissue infections is the topic for today. That's it. And we are going to go after things in sort of a case-based fashion, best I can. But as promised, before we get into this, I just want to make mention of a couple things really quick. First of all, do you guys have any questions or concerns about anything? You had the exam last week, you saw your results, we talked with some individuals. If you have questions or concerns about that, just reach out, okay? God bless you. All right, 3 antibiotics. I want to go over real quick. Clindamycin, linezolid, and metronidazole. I can post a PowerPoint presentation for this stuff, but at the heart of it, really what I want you to know, first and foremost, mechanism of action. What's the mechanism of action of clindamycin? Bless you. Okay. Clindamycin is a protein synthesis inhibitor. It shuts down protein synthesis. It's going to be important, not necessarily for its antibacterial effects today, but for its global effect on protein synthesis as we start talking about toxin-producing bacteria, okay? Clindamycin binds in a site that pretty much overlaps with the macrolides, okay? So if the macrolides bind here, clindamycin binds here, all right? And as a result, you see a decrease in peptide-forming reactions. You get truncated proteins, and you get a cessation in protein synthesis, okay? Clindamycin has activity against gram-positive organisms and anaerobes, okay? Linezolid. How many of you have dispensed or seen linezolid or Zyvox used? Anybody? A little bit? Outpatient, inpatient? Inpatient, okay. Anybody else? So to me, that's actually a good thing because that suggests judicious use of the antibiotic resources that we have. So linezolid is also sort of a protein synthesis inhibitor. It will shut down protein synthesis. And what the crystal structure of linezolid bound to the bacterial ribosome has suggested is that it sort of binds at this interface between the A site and the P site in the bacteria ribosome. And in doing so, it skews the ribosome. It makes it difficult then for things to align and transfer and synthesize. So globally speaking, linezolid is a protein synthesis inhibitor. We like to ascribe a bacteriostatic effect with protein synthesis inhibitors, but a lot of times that's concentration and bacterial species dependent. In some bacteria, linezolid is going to be bacteriostatic. In other bacteria, it may be bactericidal, okay? We only use linezolid for gram-positive infections, and linezolid should really only be used for difficult to treat or drug-resistant gram-positive infections. And you guys can name those organisms, okay? So MRSA, it's an alternative to vancomycin for MRSA. It is an alternative to daptomycin for VRE, okay? It is an alternative for individuals who can't tolerate vancomycin or have adverse effects with daptomycin, right? So it has its role in the clinic. Just have to make sure you're using it judiciously, okay? And then lastly, metronidazole. So we've talked about metronidazole several times throughout the semester already. Dr. Lewis has made mention of it. This is the drug of choice for what type of infection? A UTI. A little bit more specific. Anaerobic infections, okay? Anaerobes in particular. So drug of choice for anaerobes. Anaerobes. How does it kill anaerobes? So when you look at the structure of metronidazole, all right, it's got a nitroimidazole ring attached to its structure. Right? So here's the nitro group, and then here's the imidazole ring. And in the anaerobic environment, right, of the bacterial cell and its site of infection, this nitro group can get reduced several times. Right? And in the process, during this reductive conversion of the nitro to the amino group, you're generating a lot of oxidative molecules, oxidative stress. Right? So reactive oxygen species are being generated in the site of infection. And when the bacterial cell, which has an enzyme, a nitroreductase enzyme, is working on this group, you're generating these oxidative molecules that can go on and damage the bacterial chromosome, damage the DNA in the bacterial cell, damage the RNA, maybe even damage certain proteins. Okay. reactive oxygen species getting turned on to cause the damage. These reactions that reduce the nitro group can only occur in an anaerobic environment. Okay, because if you put oxygen in the environment, that reductive effect is gone. Okay. All right. Anaerobes. And you'll see why this is important as we move forward today. Any questions about this? Okay. Hello. Just you ever want to just throw something? I'm having one of those moments right now. I just don't get it. All right. So here's our objectives. We're going to talk about an infection called impetigo, and then something a little bit deeper called ecthyma. We'll progress into some simple purulent infections, folliculitis, furuncles, and then carbuncles. We'll spend a little bit more time on abscesses. And then we'll get into cellulitis. We'll define what erysipelas is and differentiate cellulitis from erysipelas. And then we'll get into some more appetizing infections, like necrotizing fasciitis, and then bite wounds as well. We will cover these latter two infections, diabetic foot infections, and then osteomyelitis, but that'll be next week. Are there risk factors for any and all of those aforementioned infections? Absolutely. So what patient population is at risk for each or any of those? And then importantly, and this is where I think the handout that I just gave you will come in, we have to have an idea about our approach to treating a patient with an infection. You know, how bad is it? Do we need to give this person like IV antibiotics, broad spectrum right now and admit them? Or is this person doing okay? You know, they just have this little lesion and we can send them home with oral antibiotics. How do you make that decision? Well, mild, moderate, severe, the absence or presence of Sears criteria, systemic inflammatory response syndrome. All right. Is it one-ish? Is it more than one? If it's more than one, what other comorbidities does that patient have that predicts a poor outcome if we don't treat appropriately and aggressively? Right? So we'll work our heads around mild, moderate, and severe, and then discuss some approaches to treating an individual with a mild to moderate or a severe infection. Okay. Skin and soft tissue infections are by far one of the more common infections that you'll encounter. Many people go to the ER because they have something funky on their leg, their back, their arm, and other places. Other people go to their just primary care physician, all right, for the evaluation of a lesion on the skin. And they are going up and up in number. I mean, just look here, ER visits alone, 1.2 million in 1993 to 3.4 million in 2005. That's old data. What do you think it is now? Don't have that information at the ready, but it's going to continue to go up. And those that are getting admitted for a skin or soft tissue infection increased 30% virtually in a 4-year span. So what this signals is that there is a lot of nasty infection circulating in the community, not just in the hospital, in the community. And we don't really know. I think they're going to continue to grow because when you go back in time and you look at MRSA, MRSA was largely a hospital or nosocomial infection. You went to the hospital to get treated for something. While you were there, you picked up MRSA, colonized with it, and then leave with it. Okay. Now it's everywhere. It's in the community. Community acquired MRSA. No shortage of it. And the presence of community-acquired MRSA is sort of being blamed for this spike or this just drastic increase in the number of visits for evaluation of a skin lesion. Okay. And then when we talk about the skin, I mean, if you were to take a section of skin and just divide it up in certain parts, you're going to start to realize that certain infections occupy a particular anatomical space. So if you start off at the top and you look at the epidermis, when you consider the epidermis, this is where infections like erysipelas are going to occur, impetigo, and then folliculitis. As you go a little bit deeper down into the dermal layer, this is where you'll start to see ecthyma, right? And then you'll see furuncles and carbuncles occurring, and we'll describe what all of these are. And then cellulitis, cellulitis is kind of interesting because I think cellulitis can occupy, excuse me, any of these spaces here. So cellulitis, largely in the subcutaneous tissue. And we have this sheet called the superficial fascia. And then you have more subcutaneous tissue here. And necrotizing fasciitis tends to crop up on that lower boundary of the subcutaneous tissue, right above the deep facial layer. And then this is where the muscle begins. Okay, and we can have something called myonecrosis occur, secondary to the presence of the wrong bacteria in the muscle. Okay, so we'll describe all these various infections and the layers that they infect. Keep in mind your epidermis, I mean, it's constantly turning over. Right? So you'll turn over your outer layer of skin every month for the most part. And along with that, though, you lose a lot of bacteria that are normal flora on the skin. And your normal flora on your skin ends up being pretty important, okay? Because if you have normal flora that's non-pathogenic because it's on the outside of your body and it occupies that space, pathogenic bacteria have a hard time establishing a foci. There's just not enough real estate for all of this bacteria to exist on. Okay? Your skin, it's oily, right? Like it or not, we have sebaceous glands that secrete oils that serve as a protective factor. You have fatty acids that get secreted as well, that serves as a protective molecule against a lot of different bacteria as well. And the frank pH of the skin is often unfavorable for a lot of bacteria. And you guys talked about the normal flora in the past. So coag-negative staph is a major constituent of the normal flora. You have Corynebacterium, and then you have Cutibacterium or Propionibacterium as components of the normal flora. Now, when we talk about infections related to the skin, it should not come as a surprise that gram-positive organisms are causing the preponderance of infections, staph and strep. When you see somebody come in with a skin infection, you should reflexively think staph and strep, okay? When we talk about strep, it's usually group A strep or strep pyogenes, right? Beta hemolytic strep. And then when we talk about staph, it can be MRSA, it could be MSSA, right? So there's prevalence of both. We can't tell by looking at it if it's MSSA or MRSA, however. And risk factors then for the acquisition of a skin or soft tissue infection, again, too, individuals who just don't have access to a bath, a shower, soap. And there's a lot of people in society today that have poor hygiene, not because they choose to not bathe, they don't have the opportunity to bathe. Right? So there's an increased bacterial burden on the skin. Moisture, right? Individuals that experience a lot of moisture on their bodies, sweaters, if you will. Individuals that are obese that have folds in between the folds. These are called intertriginous folds, and that creates a very, very nice environment for not just bacteria, but for fungi as well. And we must keep in mind, what is the major role of the skin in the first place? Well, the skin is supposed to serve as this beautiful barrier separating our insides from the outside world. And anytime you have a compromised integrity of the skin, when the integumentary system breaks down for whatever reason, all that does is open the door for any one of a number of bacteria to get their way into the tissue, into the bloodstream, okay? So loss of integrity, secondary to skin damage of any sort, is a risk factor for an SSTI. We have individuals who have poor circulation. We have individuals who have a lot of edema, and it typically collects in the lower extremities. So vascular insufficiency, poor blood flow to the extremities, coupled with decreased venous return, leading to a pooling effect in the lower extremities, increases the risk for things like cellulitis in particular. And then what is the status of the immune system in your patient? Well, if your patient's taking steroids for any particular reason on a regular basis, they're immunocompromised for other reasons, graft rejection, you guys are in immuno right now. How many different diseases have you talked about where you're using corticosteroids in that patient population? Not to mention one of the many monoclonal antibodies and other immunosuppressants. So there's a lot of people walking around on immunosuppression, all right? Immunosuppression, decreasing neutrophils, increases the risk of infection. And when the skin is damaged, here's a nice little cut there. This looks a little bit more offensive. Abrasions, a bruise, and then blisters, okay? The cut, I have cuts on my hand right now because it's cold out and my skin just cracks despite the use of lotion and whatnot. I can't help it. So I get paranoid about that and I put a little bit of triple antibiotic on here to help heal it. Does it work? I don't know. It's more probably placebo. But this I've never experienced. Have you? A puncture wound? It sounds awful. Yikes. Could you imagine stepping on a nail? Going right through? Think about that for a second. That's just awful. And then an abrasion. Come on. How many of you guys have been walking and then you just do one of these and hands go out as a kid, right? Yeah. So those are all good mechanisms to just introduce bacteria into the system, into the local environment. Okay? A bruise. Okay, so how many of you have ever had a bruise? Yes, all of you, right? You've all had a bruise, right? Do you have brothers and sisters? If you do, you've had a bruise, like it or not. And you've probably given bruises too. Good for you. Now, when you have a deep bruise, how does a bruise contribute then to some type of skin or soft tissue infection? Because when you think about it, this is where the damage is occurring right down in here. And when you damage the tissue deep down, when you have a bruise, you compromise the blood flow to that area. And what happens is if you have a moment of transient bacteremia for whatever reason, and it's the right place at the right time, that bacteria can get into this bruised, damaged area, right? And adhere to the damaged tissue in that area. And then when it does that, it can start to multiply. And because you have decreased blood flow and capillary flow to that area, your immune system isn't going to be as functional in that bruise as you'd like it to be. And as a result, that bacteria can start to replicate and cause inflammation. And then if it's the wrong bacteria, then it can cause something like a necrotizing fasciitis. Okay, so the site of the lesion or the wound, right, is important. The offending organism is important, okay? What toxins is that particular organism producing, which gives it an enabling characteristic to cause an infection? And then importantly too, this concept of the inoculum. How much bacteria did you actually introduce into your skin from this abrasion or from this cut? Okay, so immediately after the wound, clean the wound. If you clean it and you reduce down the inoculum that may have been introduced, that's all you might need to do. But if you let it fester, that's when things go sideways. We have a primary infection and a secondary infection with regard to SSTIs. And a primary infection is largely just it's a new infection, typically caused by a single organism in this otherwise previously healthy tissue, right? Primary infection. A secondary infection, you have previously damaged skin. You had a primary infection that didn't resolve. It generated or turned into a secondary infection. And these tend to be a little bit more difficult to treat now. They're polymicrobial. And then we have complicated or uncomplicated infections. And largely speaking, the complicated form, the deeper down, the more complicated it is. So if you involve the deep layers of the tissue, that's a complicated infection. Complicated infections often require debridement. You got to go in there, fillet the area, and cut out the dead tissue. Okay? And anybody that is immunocompromised, that has a skin or soft tissue infection, is largely regarded as having a complicated infection. Infections can be necrotizing or non-necrotizing. And remember, the definition of necrosis is just frank cell death. All right. It's cell death not mediated by any one particular pathway, not a controlled process, not a programmed process. All right. If I put my hand on a hot burner plate and burn the heck out of it, that's going to kill all the cells on my hand that came into contact with that hot plate. That's necrosis. Okay. If I have aging cells in my body that reach a point where they're not going to replicate anymore, and then they undergo apoptosis, that's a non-necrotic mechanism of cell death. And then purulent versus non-purulent. What is your concept of purulence? What does purulent mean? Pus, yes, pus, absolutely. All right, so we have pus-forming infections or purulent infections, and then non-pus-forming infections, non-purulent infections. And this is an important concept when determining what type of infection a patient has and how to treat them, okay? All right, how are we doing? Good, bad, indifferent? Moving forward. First up, some simple things, impetigo and ecthyma. So you ever work the front counter, taking in prescriptions or talking to patients and have somebody walk up with a child that has that sort of image on the bottom right there? Mom hands you a prescription for some Bactroban ointment, apply TID as directed for 5 days with no refills. And then you look over here and you take that step back because, yeah, it's one of those, right? And then you realize, this kid's got something nasty going on and he's being treated for impetigo. Okay, impetigo. Impetigo is nothing more than a superficial skin infection. It's the very outermost part of the skin, and you typically see it evolve as such. You get some fluid-filled vesicles initially, secondary to the presence of the bacteria in the superficial skin, and then they ultimately burst and evolve into these honey crust-like colored lesions that you see here and here. All right? So honey crust colored lesions are a hallmark of impetigo. And when we have impetigo, we have two different flavors. We have what we refer to as bolus and then non-bolus impetigo. A bulle is nothing more than just a fluid-filled vesicle that evolves on the top of the skin. And underneath, of course, is fluid, and it's eventually going to burst, all right, and release that fluid. So we have bolus or blistering or non-bolus. Right? Opposite to that, with impetigo being on the superficial areas of the skin, we have this infection called ecthyma. And I like to think of ecthyma as essentially the same thing as impetigo, but it gets deeper down. Okay? It gets a little bit deeper down into the tissue. Right? So ecthyma, deeper down. Impetigo, up on top. Right? Presentation-wise, may or may not be all that similar. But what's important is the treatment approach, okay? I want you to think about that for a second. If impetigo is superficial and we can get away with treating it topically, what do we do about ecthyma, which is deeper down? Sit tight for a second. Risk factors for impetigo and subsequently ecthyma. Yeah, being a child, right? Have you ever walked around in a daycare with a hazmat suit on, maybe? I mean, you want to talk about an area of society that is just replete with infectious debris. I mean, ugh, I'm so glad my kids are old and don't have to go there. Oh my gosh. Going to school, however, is that really better? Man, I'll tell you, it's amazing what kids will share. And then hot and humid environments. Not Findlay, Ohio right now, but again, too, moisture lends to the spread and the acquisition of infections like impetigo. And then the big question you're asking right now, what causes impetigo? Well, not surprisingly, strep and staph, right? Strep and staph. When you have non-bolus impetigo, okay, it's typically it's typically strep. Non-bolus is typically strep. When you have bolus impetigo, where you have those fluid-filled vesicles that form that ultimately burst, that's usually going to be staph. So non-bolus is usually strep. Bolus is usually staph. And what causes that bullae formation? Well, staph is so heterogeneous in the environment. You have certain strains of staph that can produce an exfoliotoxin A. And what this protein will do is it will actually start to cleave proteins that are responsible for cell-cell adhesion, these things called desmogleins. All right, so these are basically just protein connections from cell to cell. And exfoliotoxin A will come in and just cleave these proteins that are responsible for cell to cell connections. And then when you get that, you start to see this detachment of the skin, and then fluid will fill in, causing that bullae. And then this outer layer of skin, it's not like it's a very, very thick, hardy layer of skin, so it will eventually rupture, leading to these lesions that you see here. Okay. So how do we treat impetigo, and how do we treat ecthyma? So as I suggested early on, all you really need for a mild case of impetigo is a several-day course of Bactroban. How many times do you guys dispense mupirocin? Quite a bit. Okay, it's not uncommon. Right? So apply TID for 5 days, and that should be curative for most impetigo. Impetigo that's localized to one area of the face or the nose, fine. Topical administration is going to work well. If you have an individual that has multiple areas infected, has multiple areas of impetigo, I doubt that covering the whole face with mupirocin is going to be a good idea. And that's where you may choose to go with oral antibiotics in addition to mupirocin. Okay. Just a little bit about Bactroban or mupirocin. Bottom line, what I want you to know is that it does inhibit protein synthesis. Okay, it depletes the bacterial cell of charged transfer amino acids, thereby inhibiting the bacterial cell's ability to synthesize proteins. Okay, it's a protein synthesis inhibitor. Impetigo, since impetigo is a deeper infection, treating it from the top down is largely ineffective. As a result, we have to give oral antibiotics for ecthyma. Right? And when we have ecthyma, it's usually group A strep or methicillin susceptible Staph aureus. That's causing the preponderance of ecthyma infections. All right. So when you get that phone call, the prescriber's on the line, says, hey, I got a kid here that looks like he's got ecthyma. what can I use for treating this ecthyma? Fall back to what is usually the cause, gram-positive. What gram-positives? Group A strep and SSA. Right. What covers group A strep and methicillin susceptible Staph aureus in one fell swoop? Will penicillin work? Strep is still exquisitely sensitive to penicillin. Right? So penicillin will kill strep. But what about its counterpart, staph? No. Okay. So ecthyma, penicillin, no, not up front. What about amoxicillin? No. Nope. What about amoxicillin paired with clavulanic acid? Augmented. See a couple heads nodding here. Thinking it over? Yes, no, maybe so. Mezzanine section. What do you think? Augmentin? MSSA and group A strep? Think once for yes. No? You don't like it?
I don't know why.
Okay. It leaves a bad feeling in your stomach. But it would cover it. Okay. First generation cephalosporin? Absolutely. Yeah. Okay. So Duracet, Keflex. Go for it. Second generation cephalosporin? Unnecessary, but yes, it would work. Anti-staphylococcal penicillin, dicloxacillin. Yeah, it would work. It'll get the staph and the strep. Okay, so we want a penicillinase resistant beta lactam because the staph is probably making a penicillinase. All right, and so dicloxacillin or a first generation cephalosporin is going to be just fine for ecthyma. Keeping in mind, most of it is MSSA. All right. What if you have an allergy concern? Oh, my kid's allergic to penicillin. My kid's allergic to cephalosporins. Absolutely cannot have it. Okay. What do you do then? What's the option? Well, Bactrim. Bactrim will kill staph, both flavors. Bactrim will kill strep. So it's an option. Okay. Clindamycin, I'm just being honest, I would never recommend clindamycin for anything up front in a patient who can otherwise take other meds. Okay, clindamycin would be like the last thing that I would want to give to somebody as upfront treatment for any infection. Okay, just the risks associated with it, coupled with the increased resistance patterns, kind of makes it way down here on my list of preferences. Okay. All right. And then what if it is MRSA? Well, does your patient have a history of being colonized with MRSA? Or have they been in a healthcare facility, received treatment in a healthcare setting recently? Have they had antibiotics recently, which might put them at risk for having MRSA? And if you can answer yes to any of those questions, then maybe treating this ecthyma up front with an anti-MRSA agent might be a better option. Again, too, if it's an adult, you could probably use doxycycline or Bactrim. If it's a child, I'm probably going to go with just Bactrim. Okay. What do we use to treat impetigo? Empiricin, topically. Right. A couple times a day for 5 days. If it's multiple lesions, probably best to go with an oral therapy. Right. When you use an oral therapy for multiple lesions on the face for a patient with impetigo, an anti-staphylococcal penicillin or a first generation cephalosporin. Ecthyma, since it's deeper, requires oral therapy. Get it from the bottom up, treat with an anti-staphylococcal penicillin or a first generation cephalosporin. increases cure, reduces the risk of scarring in particular. Okay. Questions about impetigo or ecthyma? All right. Let's move forward. We'll talk about some furuncles, carbuncles, and abscesses. Oh my. All right. Here's a case. OJ. That's just Julie A. Stride backwards. I like to pick on her. She is not 35, but she is a woman who presents to her PCP for evaluation of a bump in her groin region. She reports feeling feverish at home. Okay, that's interesting. Her vital signs on presentation at the PCP's office suggest a temperature of 100.8, heart rate of 82. There's her blood pressure, and then there is her respiratory rate. PCP examines the lesion, suggests that it's an abscess, right, and performs something called an IND, an incision and then drainage. And then a swab specimen is set out for culture and sensitivity testing. OJ, this fictional patient, has a history of polycystic ovarian syndrome. Now, after the IND, what's the best approach for this individual? All right, just do the incision and drainage. Nothing else is needed. Cut, drain, clean out, send her on her way. Should we give her cephalexin, 500 QID for 10 days, Bactrim, 1 double strength tablet, BID for 14 days? Do we give doxycycline, 100 BID for 10 days? All right, think about that for a second, and we'll come back to it. So when we say purulent SSTIs, again, these are pus-forming infections. All right, folliculitis, furuncles, carbuncles, and abscesses. They're all associated with some degree of pus. And a purulent infection is typified by the presence of a drainable abscess or a drainable lesion. When you think pus, when you see pus, the default is to go right to Staph aureus. All right, Staph aureus. Can other organisms cause a purulent infection? Absolutely. Yeah, without question. Anywhere in the body. Any organism can cause any infection anywhere in the body for the most part. Right? And any organism, staph, strep, can cause a purulent infection. But when you play the percentages and you look at what's really causing these skin and soft tissue infections, it's staph. Right? It's staph when it's purulent. MSSA or MRSA. And as we suggested, the incidence of MRSA in the community has just skyrocketed. Okay. Now we've got this condition called folliculitis. And a folliculitis, listen, it's nothing more than an inflamed hair follicle is what it boils down to. All right, you've got the hair shaft that goes down into the follicle. Some bacteria got down in there. The follicle covered over maybe with some oil or some secretions, and then it didn't get washed out, and that bacteria just started to multiply there. As a result, it started to crop up, get inflamed, and now it's looking like, it looks like a pimple is really what it boils down to. It looks like a pimple. Okay. When this particular scenario happens at the base of the eyelid, where the eyelash comes into the eyelid, we call this a sty. Very uncomfortable, very unsightly. It can be painful as well. Okay. Okay. So presentation-wise, folliculitis, if you've had an inflamed hair follicle, you know it's itchy, it's red, right? And it's typically found in areas where you have friction from your clothing or areas where you're perspiring. These are small little lesions, less than 5 millimeters in diameter. So these are small papules. And if they evolve to a pustule, which ultimately ruptures, and then you can clean it out, look, that's really what you want, all right? Because as it evolves and ruptures, that's going to alleviate the pressure and any discomfort that might be associated. But this lesion is so small, it's typically not characteristic of pain. We do not see systemic signs or symptoms of infection with something like folliculitis, all right? It's not generating any significant immune reaction that's going to manifest as fever or chills or increased heart rate. Local treatment, again, that's all we really need to do for this condition. When that patient shows up to your pharmacy and wants something for that sty, or when that patient shows up and they have, you know, these lesions on their neck from shaving, or on their leg, or wherever else they're going to show you. A lot of times, if they're small, warm compresses are really what you need. Apply warm compresses several times a day to help hasten then the drainage of that lesion. And if it's not resolving, and they go and take the time to see a provider, topical antibiotics typically will take care of it as well. That'll hasten the clearing of the lesion. As it progresses, or as you see something a little bit more concerning or a little bit more painful, we go from folliculitis to a furuncle, furunculosis. This is a deeper infection, right? So not only is the base of the follicle inflamed, but now you're starting to get it deeper down, right? You're having more bacteria present. You're having more purulence formed. This is starting to look like a true infection here. This particular area is marked with erythema, redness. It's got a center here, and then this center here is probably a little bit necrotic, which suggests MRSA. It may be a draining nodule. Again, too, similar to folliculitis, areas where there's friction and perspiration. It may pop on its own. It may have a necrotic center. And while the presence of systemic symptoms are rare, if it is not taken care of, it can progress, get larger and larger, and then start to disseminate and spill bacteria into the bloodstream. So you can see hematogenous seeding and spread of bacteria from an untreated festering furuncle. So if you catch it, and you catch it early enough, again, warm compresses should hasten the drainage and resolution of the lesion. Right? Once it starts to drain, and that fluid inside can get out, and you can clean the wound or the lesion, that should be good enough. Right? But if it doesn't, you might need to actually have it go worked on by a provider. Right? Again, this concept of incision and drainage ends up being important if it's not spontaneously rupturing. And that's definitely going to be the case for a larger furuncle, or when an individual presents with multiple furuncles. And depending on the experience of the provider and the patient and patient risk factors, some providers might actually give antibiotics for a furuncle or for furunculosis. And notice what's preferred, Bactrim or doxycycline. We're going to use one of those two because when you have the furuncle and it's due to staph, you don't know if it's MSSA or if it's MRSA. Okay, so moving forward, when we see purulence and we think it's a staph infection, the default approach is to treat it as if it's MRSA and then adjust when you get results back. Assume everything is MRSA with a purulent infection, and then you can pivot once you have the results back from the lab. And then what do you get when you take a bunch of furuncles and slam them together? You get a carbuncle. And that's what's shown here. Here's a cartoon of what a cross-section, so to say, of a carbuncle might look like. And you had all of these individual lesions, all of these individual furuncles that have sort of coalesced, that came together to form this whopper of a lesion, or a carbuncle. And again, too, Staph aureus is the usual suspect. Carbuncles, as you can see, these are much larger. They're inflamed, they're swollen, they're red, they're painful. And as a result, based on size, you're going to start to see signs and symptoms of an infection. The patient may present with a fever, chills, malaise, right, and other indicators that something systemic is occurring. You often see these on the back of the neck, especially in diabetic patients, area of friction, area of perspiration. And if it's not treated, that carbuncle can start to spread into the vasculature, and the patient can develop bacteremia from that. If you don't mind scars, go for it. Squeeze it, puncture it, treat it at home. I would never recommend that. But a controlled incision and drainage is really what is required for a carbuncle if you're going to treat it correctly. Listen, with abscesses, especially large abscesses, if you don't cut it out, cut it open and drain it, it's probably not going to heal. It's very difficult to treat a large abscess or a large carbuncle medically without incision and drainage. Okay. All right. You want to take a break? Yeah, let's take a break. I have 9:51 on my phone, so let's just start back up right before 10. Okay. Bless you. So as we move forward, I just want to talk about an abscess really quick. And remember, an abscess is this pus-filled lesion that extends downward subcutaneously. And it's not one big sphere that's filled with pus, bacteria, and other cellular debris. Rather, what the abscess is formed from or composed of are these little pockets, right, called loculations. All right, so a loculation is shown here, represents a pocket. And here's another pocket. All right, here's a pocket, there's a pocket, there's a pocket, and so on. Okay, so you get these membranes that form in the context of the abscess, and each membrane enclosed area of the abscess represents a loculated portion of the abscess. And why is that important? Well, in the past, what individuals have studied and tried to do was drain this abscess with a needle and ultrasound. Right? Put a probe on the abscess, stick a needle in here, right? And then just pull out the fluid. Just pull out the pus-filled fluid. Okay. Well, how good is that actually going to be at resolving the abscess? It fails miserably, actually. Right? And the incidence of recurrence is pretty high when we do a needle aspiration as compared to cutting it open, right, and draining it. So needle aspiration is no good. However, if we lance this with a sharp implement, and then we probe the infected area. So pretend I'm going into an abscess, all right? I've gone into the abscess, and then I'm just going to kind of break up and disrupt those loculations, and then I'm going to come out, and then I'm going to drain it, right? That's far superior to just needle aspiration alone, okay? And the other thing I want to mention is this concept of surface area to volume with an abscess. So as an abscess grows, all right, the surface area will grow, but the volume grows more so. It's greater. It grows greater in volume relative to surface area, okay? And as a result, when you start to get a bigger abscess, you only have so much space where the blood supply will interface with the abscess. And since you have limited access to the abscess from the blood supply, it makes it hard for antibiotics to penetrate at any appreciable concentration. Antibiotic will get in there, but is it going to be enough? Are you going to get the antibiotic concentration up high enough in the abscess to treat it? Okay, that's why the incision and drainage becomes so critical. Right? The other thing to think about too is the pH of the abscess. All right, so abscess fluid is typically acidic. The surrounding environment is typically acidic. And if you have an antibiotic that is ionizable in an acidic environment, that's going to prevent its ability to diffuse across the membranes and get into the fluid as well. Okay. So this is an example of something that we call source control, right? Source control. And we'll talk more about source control as we move forward. Any questions about this? All right, so an abscess. This pus collection, it's fluctuant, tender, and painful. When we say fluctuant, what's your concept of this word fluctuant? When you press down on it, it'll pop back up. So you can press on it and it'll come back up. All right, so it's fluctuant. right? And it's painful. And Staph aureus is the most common offender. And we treat this with incision and drainage. Okay? Incision and drainage is far more effective than needle-guided aspiration. There's no question about it. And if we went back in time 10 years ago, probably, I don't want to say regardless of the lesion size, but for most lesions, an incision and drainage was all that was really recommended, especially for smaller lesions. Things have changed. They've done a lot of studies over the years to look at the impact of antibiotics after incision and drainage versus incision and drainage alone. And what all the data is really pointing to at this point in time is that giving a short course of appropriate antibiotic after incision and drainage actually improves upon the cure rate of the IND. It speeds up the time to resolution of the abscess, and it prevents spread and it prevents recurrence. Right? So antibiotics actually have a place in therapy for incision and drainage. So the study by Daum, I mean, that looked at antibiotics versus placebo for smaller abscesses. There's other studies that have been done as well. I'll try and summarize it here. Right, using antibiotics for skin abscesses after an incision and drainage. All right. If you have a single abscess greater than or equal to 2 centimeters, go for it. All right. Cut, drain, and then give antibiotics. If you have multiple lesions, definitely give antibiotics. If the area is marked with cellulitis, all right, so you have your lesion, you have erythema, but then you have diffuse erythema around that, which is referred to as cellulitis. That's a good indication for doing antibiotics after the incision and drainage. Remember, if we have an immunocompromised patient, it's complicated. Antibiotics. A patient that presents with systemic signs of infection, Sears criteria, whether it's a fever, leukocytosis or leukopenia, hypotension, tachycardia. Any of those are probably good indications then for antibiotic short course after incision and drainage. Sort of projecting out here, if the patient had a poor response to the incision and drainage, right? They went in, they cut, drained, irrigated, bandaged up, it's not resolving, coming back, well, open them back up, clean it out, antibiotics. If an individual who presents with an abscess has a prosthetic joint or other implantable hardware, that's definitely a good time to be using antibiotics. Okay, and in certain circumstances, you probably want to give the antibiotics before you do the incision and drainage, such that you don't seed the hardware or a valve in the heart or a prosthetic valve in the heart with bacteria. Because anytime you probe an abscess or any other part of the body, chances are you're inducing some transient bacteremia. And if you probe that abscess and clean it out, right, and you're a little aggressive with it, and you introduce Staph aureus into the bloodstream, well, that Staph aureus, being a sticky little bug that it is going to find a piece of metal or foreign material and grab onto it and try and develop into a biofilm. So anybody that has a risk of endocarditis definitely needs to get antibiotics, and most likely before the incision and drainage is done. Individuals with a high risk of transmission, not a bad idea. And then again, another study, Talon and coworkers, they just looked at Bactrim versus placebo for uncomplicated skin abscess. It works. It works. Bottom line. Okay. All right. So to sort of reel it back in, whether we're talking about furuncles, carbuncles, abscesses, or something as simple as folliculitis, any discomfort that's associated with the infection, we want to try and relieve with our treatment approaches. We definitely want to prevent the spread. We want to prevent the recurrence of that infection. So all of our measures are going to be geared at doing that. if you can identify why, what was the cause, or why is this patient presenting with an abscess, that's great. Chances are you might not even come about any type of reason why, but if you can identify that and address that, that's always good. When you look at purulent infections in particular, close physical contact is known to spread MRSA. Wrestlers, I don't know if any of you guys are wrestlers or if you have wrestlers in your family, but oh man, those wrestling mats, and just they do such a poor job of cleaning them. It's a haven for stuff like this. Again, we talked about poor hygiene and then crowded living spaces as well. I mean, anytime you're packing people into a small area, it's just bound to spread. And then this takes us to the concept of mild, moderate, or severe. And this information here should largely be similar to what's on the handout for cellulitis, but for the most part, a mild infection, whether it's an abscess or anything else that we're really talking about, is characterized by the presence of the lesion, whether it's an abscess or cellulitis, which we'll get to, right? And virtually no signs or symptoms of infection outside of the lesion itself. Somebody comes in, they've got the abscess, but they're otherwise doing well. Okay, they don't look sick, they don't feel sick, they just got this bump and it needs to be addressed. Okay, that's definitely a mild infection. If you have an otherwise healthy college-age student like yourselves, right, and you have that bump and you have a mild fever, 100 degrees or so, to me, that's a mild infection, right? Even though you're febrile, that's still mild because you're in good health. You have no comorbidities and you have no other risk factors, okay? Mild infection. Historically, incision and drainage alone would be adequate, provided it's not a big lesion, 2.5, 3 centimeters in diameter. That gets to the point where you might want to start thinking about antibiotics, okay? But for a small lesion, otherwise healthy individual, mild infection, incision and drainage alone would have been just fine. The guidelines that are still referred to were put out by the Infectious Disease Society of America back in 2014. So they're 10 years old. And a lot of the studies that I referenced here earlier came out in the time after those guidelines were published. So they are really, really due for revisions. And I think what you'll see is in the next iteration of skin and soft tissue guidelines, making it appropriate to give short courses of appropriate antibiotics for incision or abscesses after incision and drainage. All right, so that's mild. Moderate, this is where you start to see Sears criteria come up. If you have one Sears criteria, that could be considered then a mild infection, especially in the right patient. Right? You really have to use your clinical judgment in determining whether or not you're going to admit somebody and give them some IV antibiotics up front and then send them out the next day, or whether you're going to just give them oral antibiotics right away and send them out. Okay? Do you trust your patient? And when I say trust, what I mean is, do you trust that if you write a prescription for oral antibiotics, are they going to take them? Because if they don't take them, it's not going to help. Okay? So a lot of times I think what they're going to do, default, admit the patient with a moderate infection, give them appropriate IV antibiotics, see if we can learn something about the nature of the infection or assume it's MRSA, which is what's done, and then discharge them on appropriate anti-MRSA therapy for a moderate infection or a mild infection in a patient with the right comorbidities. And then a severe infection, a large lesion, 5 centimeters or greater. Individuals that have a large lesion that's painful, it has spreading erythema, meaning it's really taken off. An individual that has disease progression even after an initial incision and drainage and oral antibiotics. Right? And of course, an immunocompromised patient with the full gamut of Sears criteria. 1, 2, 3, it doesn't matter. The location of the abscess is also important. Okay, the preponderance or the majority of abscesses are probably on the back or the extremities. But when you start to get abscess in the periorbital area, okay, or in the groin, right, or in other areas of the body that start to get a little bit more concerning, maybe you're a little bit more aggressive with your therapy, right? Regardless, incision and drainage is going to be the hallmark of therapy. And then up front, we treat as if it's MRSA in the outpatient setting or the inpatient setting. And then once we learn whether or not it is MRSA or MSSA, we can adjust thereafter if needed. It's easy to adjust in the inpatient setting because it's a matter of stopping one IV antibiotic or oral antibiotic and starting a different. But when you write that prescription for that patient who's going home, adjusting is a little bit more difficult. Now you got to send in a new prescription. Now they got to go back to the pharmacy and pick up a new prescription. Okay. So how long do we treat them? Shorter ends up being better. Okay. 5 days. Right? 5 days for an outpatient, up to 10. 10 is probably too long. It's overkill at that point. Right? And if they're an outpatient, they probably have decent control over things. Right? They're probably in better shape than somebody with a moderate infection with comorbidities. Right? So a slow healer or a slow responder, someone you predict isn't going to respond as fast, like a diabetic patient, maybe you opt for a little bit longer therapy. Inpatients, 7 to 14 days is typically what has been done, but I really think this is starting to get trimmed back even more and more if possible. Okay. And importantly, incise the lesion, drain the lesion, irrigate the lesion, start the IV antibiotics, keep them on IV for a day or two. They should start to improve within those 24 to 48 hours, and then get them off IV antibiotics and start PO and get them out. Right? And again, for mild infections, oral treatment's fine. For moderate or severe, antibiotics given parenterally are really what's recommended, and those are the indications for parenteral therapy. We've talked about the Sears criteria. Rapidly progressing erythema, right? Rapid. It was 4 centimeters, then it went to 6 centimeters, and now it's up to 8 centimeters. So it just spread very, very rapidly over the course of a day or two. Progressive disease after 48 hours of oral antibiotics. All right. I came in and saw my doctor 3 days ago for this bump on my leg, and he looked at it, he cut it, and gave me a Keflex 500 QID. 3 days later, I'm not getting any better. All right. In fact, it's starting to look red and spreading again. So maybe that wasn't the best choice. Despite me having no risk factors for MRSA, the Keflex didn't cut it. And it's probably MRSA, which is why I'm not responding to the antibiotics. Individuals who can't tolerate oral. If your patient's NPO or they can't tolerate oral antibiotics, well, what choice do you have? Give them IV antibiotics. And the location of the lesion. Again, we talked about this a little bit. You know, if I have a lesion on my thigh and I have a prosthetic knee, all right, that's scary, because the last thing you want is that prosthesis to get seated and develop a prosthetic joint infection. Okay, so lesion here, joint, prosthetic joint here, IV. Likewise, if I have a lesion on my chest and I have an implantable defibrillator, IV. Okay. All right. And immunocompromised patients, IV. Unfortunately, a good percentage of patients are going to have a recurrence. So depending on when the occurrence occurs, again, incision and drainage, culture and sensitivity testing ought to get done. And then the culture and sensitivity ought to direct your antibiotic choice. If the recurrence is frequent, there's a whole decolonization approach that has been studied. And really what you need to do is make sure that that patient's not going home back into an environment where the MRSA is just hanging out, waiting for them, okay? So appropriate cleansing of the linens and the house, and then this decolonization protocol, which is twice monthly chlorhexidine and mupirocin. So twice per month for 6 months. What they'll do is they'll put mupirocin in the nasal passages, in the nares, for 5 days, and they'll take a chlorhexidine bath daily for 5 days, twice a month for 6 months. That's sort of like the decolonization approach for MRSA. How well do you think people adhere to that? Yeah, that's a toughie right there. Okay. All right, so back to our patient. Right. So the prescriber went in, did the incision and drainage, sent off that swab for culture and sensitivity results. And then in the meantime, prescribed our patient Bactrim, okay? Gave him Bactrim, gave her Bactrim because she's allergic to tetracyclines, and then we'll adjust as necessary. So she's taking Bactrim twice a day, and after day 3, this is what the lab sends back. Okay. Gram-positive coccidin clusters identified as Staph aureus. Oxacillin, it's resistant to oxacillin, so that tells you right away that it is MRSA. Okay. Despite the allergy, it's sensitive to doxycycline, it's sensitive to Bactrim, it's sensitive to vancomycin, it's resistant to erythromycin, and it is sensitive to linezolid. All right. Now, we're 3 days in, Bactrim, it's sensitive to Bactrim, it's MRSA. What do we do for this patient? Since it's sensitive to linezolid, do we switch to linezolid and give her 7 more days of therapy? Do we continue the Bactrim for a total of 7 days of therapy? Should we switch her to doxycycline for 10 days? Or do we continue the Bactrim for 10 more days? You guys are all got immunology on your mind, I know, but I'll take a guess. I really like that answer as well. Bactrim for 7 days is really all that's needed here. She's young, otherwise healthy. No reason to give her prolonged therapy. We did a successful incision and drainage. All the antibiotic here is going to do is just help clean things up, prevent recurrence, prevent spread, hasten the healing process. All right. We don't need to use linezolid in this scenario. Let's use linezolid when linezolid is needed, okay, when other stuff doesn't work. We don't need to give 13 days worth of Bactrim either. All right, so we rule that out. And of course, a tetracycline allergy would preclude the use of doxycycline. I have a question for you guys. And I know I like to talk and I talk too much, but it's resistant to erythromycin. Okay, and then we have this clindamycin asterisk. If you know that this organism from the wound is resistant to erythromycin, would you predict that clindamycin would be active in this infection? It's MRSA. It's community-acquired MRSA. I see a couple people nodding their head no. Tell me more. What's your feeling? What's that? They both inhibit protein synthesis. Absolutely. Tell me more. What's specific about these 2 drugs with regard to their protein synthesis inhibition?
Approximately the same site.
Yeah, you guys all hear that? If you have erythromycin resistance, you're most likely going to have clindamycin resistance. And this is a manifestation of what gene? ERM. Because what does ERM also go by? MLSB, macrolides lincosamides. Clindamycin is the lincosamide, okay? And have you heard of the D test? You know, on a Kirby Bauer dish, you'll essentially seed the plate with the bacteria, okay? And then on the plate, you'll put one disc, and then you'll put another disc, okay? This one has got erythromycin. This one has got clindamycin, okay? And if the staph that's growing on that plate is susceptible to the erythromycin, you'll have a zone of inhibition, and you should also see a zone of inhibition for the clindamycin. So this would come back then susceptible, susceptible, okay? What happens if you put the discs on here and then after a certain period of time, I'm just gonna take a deep breath because that's all I can do anymore. Really quick, I don't wanna take up too much time doing this, but what you're gonna see is me lose it. But besides that, same thing. Here's your erythromycin, here's your clindamycin. And your staph is growing still. Okay. And then what happens is here's your zone of inhibition. Here's your zone of inhibition for the clindamycin. But then what you see here is this zone, okay? What's going on here in this scenario? How would you describe what you're seeing here? Where the erythromycin has this small zone of inhibition, which the lab is going to call resistant due to the diameter. However, on the opposite side, you've got this huge zone, right, that the lab would otherwise call sensitive, but over here, you've got an equivalent zone to suggest that it's resistant. So what's going on in this scenario? Anybody have a thought? So this is an example of inducible ERM, okay? So erythromycin is filtering out from the disc into the local environment, and those bacteria are going to resist erythromycin, okay? But the bacteria aren't necessarily churning out the ERM gene to any appreciable effect here on the right. Over here, because there's nothing to induce it. However, as the antibiotic diffuses out into this area, what it's really doing is it's telling the bacteria, it's telling the staph, start producing this enzyme to reduce the effects of these antibiotics. Okay, So this is the double disc diffusion method to test for inducible ERM resistance. Okay, does that make sense? Yeah, sir.
So is this testing would there be a large zone of inhibition?
It should be, yeah.
So does that mean that the device is?
No. No. In fact, what's going to happen is if you start the patient on clindamycin, okay, and they may have this initial improvement in their symptoms because of what you observe on the right, but then as the infection adapts and detects the presence of the clindamycin down the road, it's going to start turning out the ERM gene, turning on the ERM gene, and it's going to result in a treatment failure. It's almost equivalent to what you see with inducible AMP-C and beta-lactamases, okay? You start the patient on ceftriaxone, they get better, for a day or so, then boom, they crash. Why did they crash? Because the bacteria figured out what was going on. They turned on a gene to make an enzyme that had the capacity to address the antibiotic, okay? If you put it on there long enough, the clindamycin will ultimately fail. The erythromycin is a more potent inducer of the ERM gene.
So like when doing this, you're not testing if the ERM gene is present, you're testing this potential for the ERM gene?
Yeah, if you see this particular display, the ERM gene is there. Yeah, it's there, but it's either constitutively active or it's inducible. If it's constitutively active, you'd go back to what we saw initially with two very, very small zones of inhibition, and the clindamycin wouldn't even touch it. When it's inducible, though, as shown here, this is when you see this sort of D, this ellipse here, where you have this zone because there's nothing inducing it. But then over time, it will get induced, but the erythromycin here is turning on the gene that produces the dimethyltransferase that results in the clindamycin resistance. Okay, does that make sense? Questions? Okay. All right. Let's shift over to some non-purulent infections then. So here's another case. We've got JJ, who's a 55-year-old that goes to the ER for this lesion on her face. It's bright red and edematous. It started about a day ago and hasn't really spread much since. This redness covers a particular portion of the left side of her face. It's raised. It's got well-defined margins. She's slightly febrile. Heart rate and blood pressure seem to be relatively normal, as does her respiratory rate. And she's got no known drug allergies. So considering this type of lesion on her face, what's most likely causing her infection? It's probably one of those two, right? So as a result, we'll just throw out the other three right now, and then you can come back to this and answer it. Right now, what we're really referring to are two different types of infections. One's called erysipelas, and the other one is then called cellulitis. Erysipelas is a superficial skin infection, mostly involving the lymphatics. And erysipelas is characterized by a red raised area with these really, really, really well-defined margins. It's almost like you could run your hand over the lesion and then it drops off where the normal skin occurs, okay? So that's very, very well demarcated is what they like to say. Cellulitis, on the other hand, again, it's a skin infection and it typically involves deeper tissues, and it's not marked by any well margin and it's not demarcated by sharp borders. It's more of a diffuse erythema. And if you could feel this, if you ran your hand across this lesion, the erysipelas lesion would go up and then it would come back down, okay? The cellulitis, on the other hand, it's here, it's here, it's here, and then it's not as red here, but it's really red here, and then it kind of lightens up again here. And we talked about an abscess already. Right, so here's another viewpoint of erysipelas on one of the extremities, this bright red area. all of this. I mean, there's no question where the lesion stops and where the lesion starts, right? So it's the borders are very, very easily defined. And then cellulitis, on the other hand, is just kind of all over the place, okay? Both cellulitis and erysipelas are largely considered non-purulent infections. I'm not going to sit here and tell you that you'll never see a purulent cellulitis, because the first one you see on appies will probably be purulent. They'll be like, man, Dudley, you were way wrong. But nonetheless, the majority of cellulitis, 99 point whatever percent, are going to be non-purulent. And because they're non-purulent, they are almost always due to group A strep. Okay? Almost always group A strep. Likewise, erysipelas. Tell me if you ever see a case of erysipelas. I've never seen erysipelas. Okay, I've seen cellulitis. I've never seen erysipelas. Likewise, erysipelas is almost always due to group A strep. Erysipelas doesn't necessarily have a lot of systemic symptoms associated with it, but cellulitis can be mild, moderate, or severe. Fever, tachycardia, even some confusion in severe cases. Hypotension, that's a kind of like a poor harbinger for outcomes. That means the patient's probably headed towards more of a septic route. And then leukocytosis, as the white count goes up, you've got a bad infection. Risk factors, very, very similar to what we described earlier. Any type of loss of integrity with the skin will predispose to both erysipelas or cellulitis. Recent surgery, I mean, you literally cut into the skin, so that's definitely going to create an opportunity. Poor circulation and edema are risk factors for cellulitis in particular. Obesity and immunosuppression. Group A strep. Group A strep. All right, cellulitis, group A strep. Erysipelas, group A strep. Non-purulent, group A strep. Right. The bad thing is that, on any given day, you'll have a patient going to the ER and they will raise their pant leg, and the attending or the resident will see this spreading erythema on their lower extremity. And, the attending in the ER or even the resident in the ER, they just don't have the confidence or the experience that an infectious disease physician is going to have. So what's the reflex going to be? They're going to treat it as if it's MRSA. They're going to treat it like it's MRSA until proven otherwise. Much like we described for abscesses, for cellulitis, we have mild, we have moderate, and then we have severe infections. And that's where I would encourage you again to look at this handout. Figure 2, non-purulent cellulitis, okay? Mild non-purulent cellulitis, again, too. You have a lesion, a small lesion on some part of the body. It's not draining any pus. The patient is lacking any systemic signs or symptoms, lacking Sears criteria. So what are we going to do for that patient? Well, if they're like you, otherwise healthy with a cellulitis, okay, fine. Let's put them on some oral antibiotics and send them on their way, okay? Because mild usually lacks Sears criteria, okay? And if you're playing the percentages in an otherwise healthy individual with no comorbidities in a mild infection, penicillin, VTIDs, if you will, if you're confident, or a first-generation cephalosporin, or an anti-staphylococcal penicillin, okay? What are most going to use if they're going to prescribe PO? Probably one of those. And why is that? Well, I'm pretty sure it's strep, but there's a chance it could be MSSA, and if it is, I can kill that too with the cephalexin or the dicloxazole or the cefadroxil. When we get into a moderate infection, what does the handout say? Again, no purulence. That's important. One or more Sears criteria. Febrile. elevated heart rate, elevated respiratory rate, leukocytosis, or leukopenia. Okay. So if you have one or more of those in the right patient, you're going to characterize them as having a moderate infection. And when you have a moderate infection, empirically, you could go with IV penicillin. And I think the more experienced ID physician that might be happen to be in the ER at this point in time might recommend that. But I think, based on what I've seen, in a patient with no risk factors for MRSA and cefazolin, perfect. Right? I don't want to use clindamycin. And then Rocephin, ceftriaxone. Right? Ceftriaxone has really good activity against group A strep. I don't want to use Rocephin for MSSA if I don't have to. It turns out that cefazolin or an anti-staphylococcal penicillin actually lead to better outcomes over Rocephin. Okay. If you have risk factors for MRSA, that changes everything. It changes everything. Your patient has a history of being colonized with MRSA, that changes everything. How do you know that? Well, hopefully that's in the EHR somewhere. Right? Recent antibiotics or recent healthcare exposure, those are risk factors for MRSA. A person who injects drugs, IV drug user, right? All bets are off. You treat that patient as if they're walking around colonized with MRSA everywhere, okay? And then this is where it gets a little, I think it gets a little bit controversial. Systemic signs of toxicity, fever, hypotension, sustained tachycardia. I mean, we've talked about those as Sears criteria already. So I think that's where you really need to just use your clinical judgment. If they don't have any other risks, but they're sick, you have to use your clinical judgment. Do they have other comorbidities that might predict MRSA or a poor outcome if we don't use the right antibiotic up front? And that's why I think the knee-jerk reaction in the ER is to give something that is going to cover MRSA up front. Not saying I agree with it, but I understand it. I get it. All right. And then when you have a severe cellulitis, when we say severe, I mean, what we're really talking about is someone who comes in, big, rapidly spreading lesion. They look sick. They have a lot of symptoms. They may be immunocompromised. If the skin is sloughing off, I don't think that's ever good. If they have evidence of any type of organ dysfunction, suggesting that they're going into sepsis, that's a severe infection. Or if that patient did get oral therapy and they failed it, right, this is all of a sudden round 2, and it heightens the severity. When you have somebody coming in with a lesion on their leg or their arm, and they're complaining of pain, and it's the pain level that they're offering you is kind of ridiculous. Like, they're in so much excruciating pain, it just doesn't even look like it could be that painful. That tells you that it's much more severe than it is. And that's when you need to start thinking about necrotizing fasciitis. And that's where they're going to have to consult the surgical team to come in and investigate as well. But nonetheless, when you have somebody with a severe infection and you're really not sure, broad spectrum empiric therapy with vancomycin to cover the MRSA. Again, vancomycin will kill strep. We don't want to use it for strep, but it will kill strep. And then we need to use something that's going to kill also gram-negative organisms and probably anaerobes as well in this acute setting. And then once we learn more from the lab, that's when we can change things. Okay. So the severity of the illness is really the dictator on whether or not you go PO or IV, the absence or presence of symptoms, in particular in comorbidities. They all play into your initial choices. Okay. Do you cover MRSA with your empiric regimen for cellulitis? Again, hearkening back to what I just said. Does your patient have any type of immunocompromised state? Are they on infliximab? Are they on steroids? Maybe, maybe not. If they're immunocompromised, you initially treat for MRSA, injection drug user, known history. If it's purulent, well, if you see any pus from the cellulitic lesion, you treat it as if it's MRSA. So any of these, yes. You want to make sure you hit all of those, okay? All right, going back to JJ. So what was JJ's issue? Do you remember? What did she have?
Abscess on her face.
She had a lesion on her face. We don't want to call it an abscess just yet, okay? Because there was no purulence associated with it, all right? But she had a lesion on her face. And what was characteristic of that lesion? It was raised and it had good bright red raised with clear borders, okay? So based on what I just told you, what do you think she's presenting with? Does she have cellulitis or does she have erysipelas? Erysipelas, okay. If you know she has erysipelas, what is the most likely cause of the erysipelas? Group A strep. What drug is group A strep exquisitely sensitive to? Penicillin, amoxicillin, and so on. All right. What if you have a little bit of doubt? What if you're, yeah, you know, it looks like it's erysipelas. I'm pretty sure it's erysipelas, but distinguishing between erysipelas and cellulitis can be difficult. So I want to give something that I know will kill group A strep, but maybe also cover a little bit of MSSA because she doesn't have any risk factors for MRSA. How does that change your approach? Do you think we need to admit her and give Pip-Tazo and Vanco? No, I don't either. Do you think we need to admit her and start Ansef or cefazolin? Do you think we should discharge her home with Bactrim? There's a consideration. How about discharging her home with cephalexin? There's a consideration as well. Okay. My personal opinion, I like the cephalexin route because cephalexin will kill group A strep. It will kill MSSA, right? And nothing kills like a beta-lactam. Is Bactrim wrong? Bactrim will kill MSSA. Bactrim will kill MRSA. Bactrim will kill group A strep. Okay. Is C wrong? Is it incorrect to admit her and give cefazolin initially? I don't necessarily think it's wrong, but it's certainly not needed at this point. If she was coming up with more signs and symptoms, had more Sears criteria, and had comorbidities, then maybe you do that. Maybe you admit her and give her some Ansef. And in fact, maybe they give her a dose of Ansef right in the ER. All right. And make sure she tolerates it and then send her home on something oral. That's most likely what's going to happen. So what I need you guys to understand, based on your experiences, what you've seen and what you're going to see, is that there is no cookie cutter approach to all of this. And you need to also understand that guidelines are guidelines, but not everybody follows the guidelines. And the guidelines need to evolve, okay? So you may go to hospital down in Columbus where they give Vanco and Pip-Tazo and then send her home on something. You may work in Toledo and they just send her home with oral. And then you may work over in Cleveland and their approach is completely different. Okay, so what's the variable in all of those locations? Who's seeing the patient and what their experience is. Okay. All right. Couple minutes. Let's talk through this last case and then we'll be done. Here's another 55-year-old dragged to the ER by his wife. He's got right leg pain. He had a fever. His leg began to get red 2 days ago after a bug bite, but the redness is swelling. So he has what we refer to as spreading erythema. Okay. His leg is warm to the touch. All right. That's called calor, C-A-L-O-R. It's very red. That's rubor. It's edematous, dolor. Or no, edematous is tumor. And then pain is dolor. So have you heard of rubor, dolor, calor, tumor? All right. That's the 4 terms that you use to describe inflammation, essentially. There's no purulence, though, even at the bite. There's his temperature. He's febrile. Agreed? All right. His heart rate is up. Agreed? Blood pressure is low. He's respiratory rate's pretty high, too. His white blood cell count is elevated, so he has leukocytosis, preponderance of neutrophils. His past medical history is positive for hypertension. He had a thyroidectomy, and he had a recent hernia repair 2 weeks ago. No known drug allergies. Okay, so here's his leg, and that looks pretty bad to me. Look at how much of the lower limb is covered with erythema, and it's edematous. So what do you think he most likely has? What's that? You think he has MRSA? All right, so I got a vote for MRSA. Okay. And I can't rule out MRSA. You know, there's no purulence, but again, too, just because there's no purulence doesn't mean it's not MRSA. What else could it be? We have MRSA as an option. If it's MRSA, then it theoretically could be MSSA, but it also could be, the most common cause of cellulitis, group A strep. And when you look at this lesion, I don't know how well that is defined or not. Right? What do we do for somebody like this? Let's agree on a couple things or disagree on a couple things. Do you think he needs to be admitted? How many of you agree with that? I say admit him. Okay. And then if we're going to admit him, that means we're going to give IV antibiotics, correct? All right. So when we give IV antibiotics, what are we hitting them with? Are we going broad spectrum, or do we think we can narrow it down right off the bat? Yeah, we need to give some broad spectrum antibiotics to this individual right off the bat because of his history and because he is very sick and because this is a large area of infection. Okay. So we're not going to do that. There's nothing to cut and drain here. He doesn't have an abscess. All right. We do need to admit to the hospital. Okay. And we probably need to give him something like vancomycin and Zosyn, or vancomycin and cefepime. Okay. Or vancomycin and a carbapenem. Admit to the hospital and just start Dapto. If you knew it was gram-positive, great, but we're missing some other coverages here initially with just Dapto alone. Likewise with the Vanco. Okay. Right. We started him on Vanco and Zosyn. A couple days later, he's still in the hospital. 2 days later, lab says, guess what? We got gram-positive cocci chains. We identify it as group A strep. What do you do now? What's the first order that you write? Stop all antibiotics, right? Stop the Zosyn and stop the Vanco. Start group A strep pyogenes. What do you want to put them on? Penicillin. 4 to 5 million units IV Q4 hours. Done. Identify bug, kill bug, go home. Dr. Lewis will be in on Wednesday to talk about some respiratory tract infections. When we meet again, we'll pick up with necrotizing fasciitis. We'll go into diabetic foot, bite wounds, and osteomyelitis. Good luck on your immuno exam.